Hello, my name is DM. I, alongside with my team members Catherine, Leah, Sadia, and Liz, will be discussing dysphagia in stroke patients and our resource we have created. Dysphagia is defined as difficulty with swallowing and is a common complication of stroke. A substantial proportion of all stroke survivors have clinical signs of swallowing dysfunction shortly after stroke onset, with the majority of these patients experiencing recovery. Many stroke patients recover rapidly, however significant problems persist for a minority. As many as 35% still have difficulties after 3 months. Incidence rates are reported to be somewhere between 29 to as high as 80% in acute stroke patients. The reason behind the variability is the discrepancies in the timing and method of a swallowing assessment. Studies have found that dysphagia occurs in up to 80% of stroke survivors within the first 2 days post-stroke, 50 to 80% within the first week, and 64% within the first 10 weeks post-stroke. Dysphagia affects the swallowing process and in turn makes drinking, eating, taking medicine, and even breathing difficult. Clinical evidence reveals that dysphagia is associated with poor patient outcomes and has been proven to be detrimental to health. The most clinically significant symptom of dysphagia is aspiration, which is when material passes the vocal folds and enters the airway. Hospital patients with an impaired swallow due to neurological injury, including stroke, are at high risk of aspiration. It has been found that about 1/3 of stroke patients aspirate on a video fluoroscopy. Silent aspiration refers to when an individual aspirates with no outward signs or symptoms such as coughing or throat clearing. For this reason, it is difficult for healthcare professionals to detect silent aspiration without utilizing a more objective swallowing assessment tool. The incidence of silent aspiration in patients who have dysphagia following a stroke is reported at 28 to 39%. Aspiration following stroke has been found to be associated with pneumonia, sepsis, and death. Up to 1/3 of stroke patients suffer from pneumonia, which as a result increases morbidity and mortality rates of this patient population. According to researchers, pneumonia is the second most common cause of mortality during the acute phase of stroke. It has been found that as high as 3% of stroke patients die due to aspiration pneumonia within the first 3 months, and from 6 to 20% die during the first year post-stroke due to aspiration pneumonia. Therefore, it is important to identify aspiration because of the consequent increase in pneumonia. There are many other negative outcomes associated with dysphagia. These include, but are not limited to, aspiration pneumonia, as mentioned, dehydration, malnutrition, a decrease in an individual's independence, a decrease in an individual's quality of life, and could potentially lead to death. Compared to stroke patients without dysphagia, stroke patients with dysphagia have higher rates of disability, chest infection, aspiration pneumonia, dehydration, and malnutrition. Dysphagia in stroke patients is therefore associated with a significantly higher risk of death, especially in the first 90 days. There is also a higher rate of increased length of hospital stay and institutional care within the stroke population who have dysphagia. The evidence suggests detecting and managing swallowing difficulties earlier on and utilizing best practice methods in acute stroke patients improves patient outcomes. It can reduce the severity and amount of medical complications, including a decrease in risk of pneumonia, dehydration, and malnutrition. It has been reported that the number of swallowing complications seen in stroke patients is correlated with the length of hospitalization. Therefore, it also benefits the hospital as it reduces the length of hospital stays, the number of hospital stays, and therefore overall healthcare expenditures. Dysphagia is a marker for poor prognosis in acute stroke patients. Thus, a comprehensive set of guidelines targeting dysphagia in stroke patients will help to reduce complications in this population. I will now hand it over to Catherine, who will talk about our search strategy when looking for clinical practice guidelines targeting dysphagia in stroke patients.